So let me turn to Steve, because I think that we'll come back and we'll summarize some of the issues, and I think try to put it in perspective. But I think that Steve has already been introduced to you, but I think that let me put his job in perspective. At the WHO, the single most difficult job is the Director General's job. This is an almost undoable job, I'll be very blunt. But I think the second most difficult job is the legal officer's job, because when countries get into a fight, when countries are really struggling about how to answer something or address something, the initial reaction is to turn to the legal officer, and this often occurs during the World Health Assembly when literally every country in the world is looking at that one person to address a question which the countries cannot easily answer themselves. So that's been Steve's job, and he was very much and his colleague Gianluca Berti were very involved in these discussions. So Steve, can you provide some of the perspectives from WHO?
Sure. Thank you, KG. Thanks very much. And I don't think my job is quite that difficult, though. I mean, it's challenging and interesting, but the jobs that always amaze me about WHO, and we've heard from many of these people, are the people who actually go into the field, as KG has done, and operate really on the sharp end. And that is an extraordinary work that my colleagues at WHO do. But let me sort of go through sort of a couple of questions, and to answer a question that may be in some of your minds. Not all of you are familiar with how WHO processes work, and you've heard Ambassador Wibisono and Ambassador Lang talk about the PIP process, and that it took 4 years. Okay, so why did it take 4 years to get to this? From a problem, the problem was the sharing and the issues of equity, to the production in 2011, the delivery of this purple book. Well, let me give you some stats I've just quickly jotted down for what happened over those 4 years. So this book has 60 pages. If it's roughly 250 words per page, that means that every month produced 1.25 pages. So a little over a page a month. And if you break that down to words per day, that was 8 words per day. So it doesn't operate very quickly, but it operates in a way that assures at the end of the process consensus, because primarily the WHO and the World Health Assembly operates on consensus, which means 194 countries, if they don't generally agree on the outcome. Generally agree doesn't mean no one objects. It means no one objects strongly enough to block the adoption of the framework. Now, a couple of things about the framework and what made moving that quickly possible, because that's relatively quick compared to some other processes. The processes that resulted in the adoption of the Framework Convention on Tobacco Control took longer. The processes for the IHR took about the same length. The Pandemic Influenza Preparedness Framework is not a legally binding document in toto. So that was one of the early issues which came up, and it was decided to do it as a resolution of the Health Assembly, that is to say, a recommendation of the Health Assembly. There are legally binding elements in the PIP framework, which is another of its novelties. It includes legally binding under international and, following that, domestic law of contracts with vaccine manufacturers, for example. But the process starts, as Ambassador Wibisono said, with a resolution of the Health Assembly providing a mandate, and that's what happened in 2007. That wasn't the Secretariat of the Health Assembly. That wasn't the DG herself. That was the member states getting together and say, we need to solve this problem. We need a framework to solve this problem. We don't know what that is yet, but we need something to ensure that we have rapid and robust sharing, and something to ensure that we have benefits on an equal footing with that sharing. And from that point where the mandate is developed by the Health Assembly to where the Health Assembly returns to consider the work that it has mandated, the work done by member states primarily, facilitated by the Secretariat, that takes 4 years. And there was in that process issues which you've already heard described, and the results Anne will give you. But I will touch on one thing which Anne is going to mention, and which we are dealing with today. At the very end of the negotiations, this was in the executive boardroom of WHO, which is one of the more impressive rooms of WHO. There's very little in WHO which looks like the movies think WHO looks like. I mean, our offices are really Formica floors, not very nice. But the executive boardroom of WHO looks like the movie suggests. And in this big room at 6 o'clock in the morning, the issue that was blocking consensus was the Nagoya Protocol. The Nagoya Protocol was just being negotiated at that time. It was just beginning to be understood how it would impact all sharing of pathogens, including the sharing of influenza. And there was disagreement about whether the PIP framework should, at that time, reference the Nagoya Protocol. Ultimately, it was decided that it was too early. It would not. And we are still now, that was 2011 in January. We are now in 2018. And in fact, next, in January 2019, we'll be returning in that same executive boardroom to again consider the implications of the Nagoya Protocol now on the PIP framework. So 9 years have passed. We'll still be dealing with the same issues. It may take another 4 years or more to address these, but you'll understand after hearing from Ann Huvos why these new issues of the Nagoya Protocol and its effect on PIP are so important and so difficult to address. So,
Thanks, Steve.